off by asking, I'll actually ask Sana-Ara. MJ talked about how there's evidence gaps and potential need for more understanding around individual responses to cannabinoids. So in your practice, have you seen like really variable responses or even adverse drug reactions from use of cannabinoids? And how would you see the potential of more information on how people respond?
So just to clarify, the question is in regards to my clinical practice, if I see variabilities in the patient populations, and absolutely, I see variabilities in the patient populations. And the challenge really, I think, right now as a physician is that post-legalization, our products now have shifted, and there are now shortages across the country. And so we already know that based upon the plant's genetics, you're not able to replicate each grow to be identical. And so inherently there are already differences in the plant products that are being available to us. And then on top of it, when we have shortages, patients are really struggling when it comes to symptom management. And at a very basic level, there is a shift right now in Canada. Post-legalization, the demographic of the age group greater than 55 is very interested in using cannabis as an adjunct to their existing treatment, and the challenges is that they also have a lot of comorbidities. And due to the fact that they have a lot of comorbidities, they're on a lot of medications. And it's that drug-drug interaction that I'm very interested in, because it actually has a huge impact on how I prescribe their THC and CBD to be able to manage their pain. And the challenge that we have right now is we actually don't know. We don't really understand fully these drug-drug interactions, and we're in the beginnings of innovation, and we're in the beginnings of understanding how best to prescribe. And the variability, I mean, a really simple example. So I can have two 65 plus women in my practice who both suffer from osteoarthritis of their knees and some element of myofascial pain. And both of them are going to require some element of anti-inflammatory relief from CBD and some element of THC use at night to help them sleep. And if I start a product on one patient, and by simplicity in their practice, because it's so important to do so, you'd want to replicate the same ideal dosing for the next patient. But in follow-up in 3 months, it's very clear to identify that one patient does really well on CBD, but the other one doesn't. And it's so perplexing, and I chat with this with Caroline quite often, and initially both of us were like, well, maybe it's the terpenes. Maybe it is some sort of genetic variation that this person inherently has, and it's great to see Dr. Igor's talk, because this is exactly what I'm clinically seeing, is that these terpenes actually have a much bigger play than I even anticipated, and that even sometimes batch to batch, the product that's being developed by the licensed producers will also become non-efficacious. And then there have been times where I've been confounded by my colleagues who are against cannabis, who will then immediately say to me, oh, well, you're just developing tolerance, and now you're going to have a higher dose of cannabis that you're going to have to prescribe, and now you're going to have withdrawal and all the negative consequences of cannabis prescribing. And when I get stumped with those kind of comments, it's because I know better than that, because why would I have thousands of people in my practice coming to me for cannabinoid therapy and getting benefit from this? Why is there a small variability now, confounding this? And I do believe that it's really important for us as physicians to apply our clinical expertise to the science and allow researchers and scientists and academics to then kind of hone in on our challenges, because it is the collaboration of all of us together that's going to result in a better quality product. And I think it's so important right now that we deal with the shortages that we're facing here in Canada, and it may very well be that we're entering into a realm of cell cultures to help us. Thank you.
Thank you. I think there was a question up there.
Good morning. Genome, Moderator. This is a question for both Caroline and Sana-Ara. You're really at the forefront of, of sort of treating patients with, with cannabinoids. In your mind, how are the medical schools and the pharmacy schools sort of responding in their curriculum development to this whole new field of cannabinoids and THCs?
Great question. So I have a number of students that come through the clinic. We're a UBC teaching site. We have pain medicine fellows. I've got my first orthopedic fellow coming through, psychiatry, geriatrics, palliative care, but that's just the start. So the plan is, along with some other colleagues in the School of Pharmacy and hopefully other, looking at interprofessional, interdisciplinary education, is to start to create a curriculum. One of my other colleagues in affiliated with McGill, she has a cannabis clinic. She's created a set curriculum for a month elective. So that's something that we're looking to carbon copy, and I'm sure Sana's on the same page with that way. But really, we don't even teach about the endocannabinoid system in, when we talk about pain, let alone we're doing some physiology in the medical schools. So I think we have a long way to go still, and really,
Yeah, absolutely. So I appreciate that you're from Alberta and you're asking this question, because I have to admit I'm a UBC grad and we're so forward here when it comes to cannabis in British Columbia. And I have to admit that Alberta is the #1, consumer of cannabis right now in Canada. We have no idea what we're doing. So unfortunately, across Canada, as an anesthesiologist, simply put, I never got taught the physiology for endocannabinoids. No idea. I am a self-taught physician from 5-6 years ago, and when I had to study a retrograde signaling system without any assistance, it was absolutely challenging. And so we really need to understand, at the foremost, why we want to study cannabinoid medicine. And I think the answer was very much clearly demonstrated by MJ and Caroline. We have an opioid overdose crisis in Canada and across the globe. And if we're going to address that as our foremost issue, then we need to understand the signaling systems, we need to understand the physiology, so we can create new science and understand how to innovate to help those individuals. And it comes down to a very basic level. I urge, everyone to approach their MLAs and go to the government level, actually, because I can talk all I want about how great cannabis is to a bunch of doctors and scientists. We're the ones who are academic, but what we really need is lay people going to their MLAs and to their MPs and lobbying their government to actually advocate that, I pay taxes, I'd like my doctor to be more educated. What's the next batch of students going to be learning when it comes to cannabinoid medicine? What if I'm 75 years old on warfarin and I'm getting a high dose of CBD and I have a fatal intracranial hemorrhage because there's an interaction between CBD and warfarin that can result in prolonged warfarin effect? What if the med students don't even know this? So it's really important to ask those questions. So thank you so much for that question.
Okay, question up at the back.
Thank you. I have a question for Dr.
Wait a second, we can't really hear you. Does anybody else have their question for us? Okay, we'll do this question first and then we'll come to the back. Okay, stay on control of the mic. So you can press the microphone button there. Yeah.
Well, thanks, Kelly Svensson, the Gary College. Question for Dr. Kovalchuk. You used the phrase strain. What criteria do you use for strain, and did you investigate batch-to-batch variability?
Right, so we're not a commercial producer, right, obviously, so we haven't tested different batches. So the strain to be is the cannabis with a different genomic profile, let's say, right? So we have sequenced over 100 different strains, right? So we have identified SNPs, variations, whatnot, but our first approach was completely agnostic, right? So we have received, let's say, several hundreds and just started intercrossing them, right? And then started profiling all the hybrids. When we identified what's active, what's not, then we went back and checked, well, what's cannabinoid profile, what's terpenoid profile, what's the genomic profile, and whatnot. Yeah.
Okay, could you please turn your button off? Thank you. Yo, please introduce yourself.
Okay, my name is Mr. Moderator at UBC. I'm not asking about terpenes, although we worked on them for 20 years. I have a question for Dr. MacCallum, Dr. Ahmed. Can you comment on the connection between cannabis use and schizophrenia development or other neuropsychological declines?
Thank you so much for the question. So Carolyn and I are going to tag team this question because you've asked the toughest question so far. So I just presented in Europe actually to a group of addiction specialists about this very topic, and the UK has been kind of the leading research when it comes to identifying population risk when it comes to the development of schizophrenia. And there is correlation in the literature to demonstrate that those who have a strong family history are definitely at risk of developing schizophrenia. And the challenge that I wanted to pose to this entire room is that what we're facing right now is that each individual person who is currently using cannabis may not be guided by a physician. And due to this very fact, we are very challenged because we can't really do epidemiological studies because we have no controls over these individuals. And I'm going to pass this on to Caroline because she has done some interesting work in regards to identifying how CBD works in psychosis, and I can echo it too from my own clinical practice, but I'm going to turn this over to Caroline right now about a possible solution that we have.
Great. So just backing up, just need one clarification. So when we also look at populations, we need to consider if it's being used in a medical, like low safe dosing under the direction of a physician, or if this is somebody on the streets, or not on the streets, but has a cannabis use disorder, or is using very high amounts of THC in the form of shatter and dabs and very quick onset, high concentration products. So making that distinction as well, like the pattern of use is very important. And then moving on to CBD, which is showing great promise in a number of different areas. I think when we look at psychosis, I actually have a pretty large population of bipolar, actually, that's what I've been seeing. I don't have a large psychosis population, but CBD definitely seems to be the safer of the two. And we're seeing that it requires high doses, like in some of the studies, we're seeing about over 1,000 milligrams, maybe up to 2,000 milligrams of CBD a day, which is very expensive. And I don't know if that's sustainable outside of a study model, but I think really what we could see if it wasn't just CBD, is actually that when there's a little bit of THC, it's the synergy between the two, as well as some of the other cannabinoids. We have whole plant extract that we probably need a lot less than what we think we need, but for the purposes of these studies and these very sick patients, it's been CBD only being used. And the other piece to recognize is that it's being used as an adjuvant, so in addition to their other antipsychotics. And I think that's really important and something that I'm very passionate about, is this concept that cannabis is an adjuvant, or this is a great way for us to start working with it, is adding it in combination with medications, not assuming that it's better, and some people make great claims, and especially for certain disease states, we don't have enough evidence, but we know that it can help a number of symptoms. So why not use it together and then see how things go? But I do have patients that I'm able to taper down on some of their other medications while we add in and optimize these doses. But again, that needs to be done with psychiatry and with the support of a number of other colleagues, because these are very sick patients.
Absolutely, and I think the other thing that I would love to really point out here, the important here is we actually need more education at a public level. And the challenge is that majority of individuals who now post-legalization think it's very safe to start consuming cannabis may not understand that what they're actually trying to treat, they have no concept of. And the hardest thing that a patient is ever going to do is come off of their pharmaceuticals. And when they're doing that without the guidance of their family physician or a specialist physician, it is very, very alarming to me. In my practice, it's important for allied health professionals and my colleagues to be part of it. And unfortunately, in Alberta, there's a lot of stigma and still a lot of fear around the use of medical cannabis. And due to this, I'm kind of, this lone individual trying my hardest to educate. And I really, it behooves us as an individual group right here that are fascinated about the genome of the human body as well as of the plant to become public advocates, because we don't know what the effects are going to be if a patient comes off their olanzapine or their risperidone, just because they believe that now that cannabis is viably available, they can just take THC and cause more harm. And because their physician is unwilling to talk about it with them, they think it's okay just to do it on their own. So that conversation really needs to start moving forward, and we have to accept it. This is here. It's not going anywhere. Cannabis is part of our cultural fabric now in Canada, and we as empathetic physicians and researchers have to take care of our public in regards to this.
Just one quick piece I just want to add on, sorry, it's a question that's unraveling a lot of different really relevant topics. Is bringing up physicians that may not be supportive, is also the fact that the Canadian Medical Association, unfortunately, hasn't really been, not for or against, but the guidance coming from that in terms of, supporting its physician members has not been, I think, as good as it could be. And so I have a lot of patients that call the office since legalization. We probably got 200 extra phone calls a month from patients who say, my doctor won't send me to you because it's legal. They say I can go figure it out in the dispensary. However, a number of points here. The bud tenders working in dispensaries actually aren't able to give medical advice. They're not able to give cannabis recommendations really either. So at the end of the day, are they just saying, this is what works for me and this is what could work for you? So there's big concerns there. And so I really think, if we can really support physicians in education and even get them referring their patients to another physician and just not drive them towards the dispensaries, because I think there's huge mental health conditions that are being treated on they're doing their best to treat themselves, but actually they could be certainly, worsening the situation.
Thank you for the question.
Okay, at the back, press your button. Is it red? Has anybody else got the red microphone? Okay, we'll start with questions down here, and then we'll come up here. So everybody else hold your fingers. If everybody can hold their fingers, we have to control the fingers, as well as the speakers. Please introduce yourself, Julia.
My question is for MJ. Given that you are an epidemiologist, and I was wondering what your relationships were like with all of the harm reduction advocacy groups that are in the downtown side. And I'm curious to know if this has been something that they have been advocating for a long time, and if this is just something that everybody else has been just catching up with.
That's a great question. At BCCSU, we do work very closely with community groups in the downtown east side and other areas. We're very fortunate to work with groups like Mandu and WARS, who are really on the front lines of the overdose crisis, along with first responders and other community groups. And I think, going back to one of the first studies that we did, showing that there was a group of people in our cohorts who were intentionally substituting cannabis for crack cocaine. For me, the notable thing about the study was not that it was happening, but rather there were individuals who had adopted this strategy in an ad hoc fashion, right? No harm reduction person, no bud tender, no one had ever told them to do this. And yet it had sort of developed, best we could tell, organically. And I think that, that we're fortunate to have longitudinal studies, so we see the same people over time. And what we've been seeing in the last number of years is really an increasing sophistication among our participants. We've been asking them why they use cannabis, and recreation, getting high, intoxication is still one of the most important reasons for them. But we've been seeing over the last number of years an increasing number of people who say, well, I am using it for pain, or I'm helping it to address my sleep, or I am doing it to substitute for other drugs. And so I think there is more sophistication out there. There are more people who understand in our cohorts about CBD and the possible benefits therein. And so we are really trying to learn from them, right, and learn how they might be deploying cannabis to protect their health and well-being. And there are, in fact, at least 2 groups that we are aware of that we're working with who are giving out cannabis for free to people at risk of overdose in the downtown east side. One through an overdose prevention site, another through the offices of Mandu. So every Saturday they come and they give out care packages of cannabis for people at risk of overdose. Because the last point I want to make, and the last point I'll end with, is that although there's certainly no lack of cannabis in the downtown east side, as you might imagine, unfortunately our data does indicate that very few, if any, of our participants are accessing legal cannabis. It is simply too expensive, and it is not geographically convenient for our participants or people living in the downtown east side to access cannabis, either through the recreational system or through the medical system. I run a cohort of over 1,000 people who are living with HIV who use drugs, and only about half of them use cannabis therapeutically because of their HIV infection, but only a very small handful have medical authorization to get medical cannabis through the medical cannabis system. So, as we move forward, we're obviously going to be doing the work, the controlled trials, to try and understand what the benefits and risks of cannabis might be for this population. But I think we also have to keep our eyes on access, because as we've heard previously, the system is not benefiting the poorest among us, the most at risk of overdose, who are using cannabis therapeutically. Thanks for the question.
Can I just add on to that? So about that population especially, and other similar populations, So you actually need an address to get cannabis delivered legally through Canada Post or whatever courier they use. So those patients who don't have an address, that's definitely, or credit card, yes, you also need that order. And then CBD, of course, is more expensive. You need higher amounts to use that to benefit. So again, what the patients, the clients in that population actually really need is really good CBD, and affordability, unless it's in a study, is going to be really difficult. So it would be lovely to see at some point we get enough evidence that this could be covered under a Pharmanet or under some form of government subsidy for the medications. Like that's really the only way I think it's going to get out there. Just access is just so huge.
Thank you. A question at the back?
Hi, Derek DeRosier. I'm a pharmacist. A couple of things. One, I've heard you use the word dispensary to describe retail outlets, and I sort of take exception to that because it causes confusion amongst some members of the public, and in fact the regulation in BC prevents retail outlets from using terms such as dispensary or pharmacy spelled with an F or whatever. That's just a comment. But my question really for Dr. MacCallum and Dr. Ahmed is, are you sure that all of your patients that you're providing a medical authorization for cannabis are accessing it through the licensed producers and the medical system and are not going to retailers to access the product? And if they are using retailers, are they getting a different product really than they would get through the medical system?
I believe we actually have two different answers, because Caroline can speak towards British Columbia, and I can give the example of what's happening in Alberta right now. So Alberta is very unique in the sense that we were able to get the largest number of retail outlets in proportion to the population, and the regulation around it has been very provincial. So the challenge right now as a physician is that because of the shortages that are available in CBD particularly in the country, if I'm prescribing CBD, for instance, or a particular licensed producer in Alberta or Ontario or British Columbia, and it's not available on their online site, but the patient then goes on to the Alberta version of what the online store would be for the cannabis dispensary system, and they see it there, they'll purchase it. And so in my practice right now, what's actually been changing is I'm having to spend a lot more energy and time at an administrative level to make sure that I'm educating my patients to help them understand the difference between the fact that they're accessing it through the medical system versus accessing it through the recreational system. And the biggest difference really is that as a medical patient, the access point that you have, you're going to be able to possess more cannabis if you're required to do so. So the minimum right now in Canada is 30 grams, but if you're a medical patient, the maximum would be 150. The other thing also is that if you are a medical patient, you would be able to expense this through the health tax benefits through the government's, through the CRA basically. So on your taxes, you'd be able to claim this. You cannot claim recreational cannabis. The other biggest issue that I'm facing in Alberta right now is the use of cannabis in employment. And so right now, a patient who believes that they need it for sleep because they can't sleep because they're stressed, and they go to a dispensary and they purchase it. If they have a positive urine test, or they have an employer who now requires them to disclose this as per law, and they disclose they are now in a position of now losing their position. And so as a physician, I have to spend extra time now to be able to identify the patients who are going to be using this at work, the administrative work to be able to supply the employer with information of a very specific treatment plan. And so based upon my personal need to be able to explain why I do what I do when it comes to my day and night dosing, I do find that my patients are very compliant with my practice. But the effort that I have to put in is tenfold now in comparison to before. On the other hand, my biggest complaint is when I have a wife and a husband come in. The wife is on board when it comes to the medical use, but because men in Canada are the higher percentage of the population using cannabis, they still want to go to their dealer, or they still want to go to their source because they want to have higher THC, because they're still convinced that high THC is the medicine. And it's very challenging to be able to overcome this, understanding this stigma, because the reality actually is, and lecture that we had, the Caroline both have attended, at the Keating Consortium of the Investigation of Cannabinoids, is that, you know, the ideology that we had for the longest time through Health Canada, that THC was the medicine, that hypothesis has been debunked. And then the next hypothesis was, well, you know, CBD and THC together are the medicine. And now we know that that's actually not also true. It's actually the combination of everything in the plant that actually is the medicine. And Igor is really, you know, presented on that at a high level, but we really need to understand that this is personalized medicine. This is not I can just take 25 milligrams of CBD and I'm going to be fine. And you as a pharmacist will understand this even more, because the drug-drug interactions are so important to be able to recognize. And it's unfortunate that we've got a population now in Canada that just thinks that, you know what, it's legal, I can go get it, I'm going to use it, no problem. And I do think it's really important for all of us to be public advocates for our patients. Thank you so much.
Just a couple of quick points on that. So we should be calling them retail outlets. I just still sometimes use that word dispensary, but I appreciate it, especially because in Alberta now, some of the pharmacies I think are able to actually carry cannabis, so then the dispensary word becomes even more confusing. And just to clarify, it's actually not a prescription, even though we call it prescribing. It doesn't have a DIN. It's not on a normal prescription pad. It's an authorization. And further to what Sana-Ara was saying, we fax directly our recommendations and our authorizations to the licensed producer, and we do that to keep them in the medical system versus recreational. They'll just walk in and get that on their own accord. But unfortunately, what we've seen in some of the provinces, I think it was Quebec that I last read about, was that some of the CBD products were actually cheaper to purchase in the rec space, even though it was the exact same product, same label, same concentration as medical. And you can see how frustrating that would be for most of my patients making under $30,000 a year. So they're now being encouraged to go to recreational, you know, kind of discount these retail outlets to purchase certain products. So I think that is, you know, we've really got to do a better job of regulating the costs and from that perspective. And then on the employment front, I've done some medical legal work, and unfortunately, some of the things that have come across in that work is some physicians will say to their patients, use Navalone because it doesn't metabolize, well, they don't say it in this manner, but essentially Navalone does not metabolize the same way THC does, so it will not test positive in the urine. And it's got a DIN, so it means it's safer, apparently. But really, it can last like greater than 12 hours. I see many patients that last much longer than the oils. And also, because it's unopposed THC, really, it can be quite impairing. And likewise, morphine and muscle relaxants and many medications we use for pain cause a lot of impairment. So those are acceptable in the workplace. And when we pull somebody over when they're driving, we're now checking for cannabis, but we're not checking for their zolpidem and their Benadryl and their Gravol and all these other medicines. So it's really challenging in terms of, you know, teasing out all these issues with cannabis. It's just raised so many more.
I just had a quick question actually for the audience, if you don't mind. I just wanted to show, with a show of hands, how many people here know that the medications that are available, excuse me, I can't even drink water, it's Ramadan, I'm fasting, excuse me. So the quick question for the individuals here is that how many people here know that the recreational products that are available at the retail outlets are identical to the medical available in Canada? Wow, so not that many people here know that. So public service announcement, everything that is available on the recreational side is an identical product on the medical side. There is no difference. The only difference is the way they have branded it. And that's because of the way the government has asked them to brand things. But really, the challenge is, if you understand that, you can see as a clinician how challenged I am if they're funneling them exactly the same thing into a retail outlet with no access to the medical patient. And that's where these really big discrepancies are occurring. And I'm looking forward to what this afternoon is going to bring forward and how we are able to solve these issues. Thank you so much.
Thank you. Okay, we have one last question, which is over here. I already gave nod. And could you please make your questions, if they're going to ask about this question, to do it in 1 minute.
Hi there.
Okay, please introduce yourself.
Gina Conti, Chief Scientific Officer of Lighthouse Genomics. My question is for Dr. Milloy and Dr. MacCallum. I'm wondering your thoughts on the huge amount of chemical and genetic diversity in cannabis and how that currently affects your research and populations. And my question is in a few parts, I guess. So it's that, as well as, are you able to test for the effects, the differences in effects between different varieties, or at least account for them? And do you know what varieties your patients are taking, and is there an opportunity for genetic testing there?
I will speak very succinctly. That question is really at the heart of what we're wrestling with as we move toward clinical trials. As I said, sort of maybe more than 98% of the cannabis that people use in our studies are from the illicit market, so we don't have, it doesn't encompass CBD and THC ratios. We're fortunate to just get a catalyst grant from CIHR. We're going to tackle some of this work. We're going to ask people what they're using in terms of the ratios, and we're also considering sampling from the cannabis that they're using to do that sort of work. Thank you.
So in the clinic where I work, we've got upwards of 60,000 patients who have come through. They're not all currently active patients, but we've been capturing their data over the past 8 years to see what plant, what company, what percentages, and how that works. And so we just received ethics approval to be able to go through the data. We've got some work ahead of us in terms of consent, and to be able to see, is there certain medicines that work better for certain patients? Is it age? Is it sex? Is it a disease? Is it a symptom? There's so many, just a point of interest, actually, children tolerate THC much better than adults do. So these sorts of things, not that I have a big practice of kids and not many are on THC. I have a couple in extreme circumstances, but these are the sorts of things we really need to tease out, and I think that really this is where clinical data and this N of one idea needs to inform bigger studies like RCTs and other things. So we really need both types of research. You can't just say RCT is the best, that's what we need for everything, because the plant is so variable that really you have to work with it to have a good sense of how to then put more money into that research and make it meaningful.
Okay, thank you everybody. So I think we've had a really exciting and interesting discussion here. There's clearly a lot of challenges in the human health space with needing more evidence, issues around access and education. So with every challenge comes an opportunity. So hopefully at Genome BC we may have some opportunities using the personalised and precision health approach to tackle some of these issues. Our next session will be on the plant side of cannabis genomics, so please stick around. I think the two topics are very intertwined in terms of the need for understanding on both sides. Before we sign with our speakers, just some instructions. We're now going to have a coffee break. Please be back in the room by 11 o'clock. So quick